I'm Shannon Weber with the Bay Area Perinatal Aid Center. And would you introduce yourself?
Sure. I'm Mona Loufty, and I'm an infectious disease specialist, adult HIV physician in Toronto, Canada.
And we're here at the 5th Annual Women and HIV Symposium here in Seattle in February 2015. And you just gave a really beautiful talk about the work that you've done in Canada to look at the breastfeeding practices among HIV-positive women. So can you tell me, how did this come to your attention? Kind of what was your practice and where did you feel the disconnect around it that caused you to look at this?
Sure. Okay. Well, it's important to know actually that the presentation can be found from the website.
Perfect. I'll link to it in the bottom.
Yeah, the 5th International Conference on Women and HIV will have the full presentation, so people can access that presentation. And we have a group in Toronto called the Interdisciplinary HIV Pregnancy Research Group. And about 5 years ago, we started having conferences, and we had a session on HIV and infant feeding. And I was chairing that session. And the women in the audience, we practice from a community-based research model where we work with women with HIV, community-based organizations, clinicians, researchers all together. And we were all together in the room talking about infant feeding, HIV, and one of the participants raised her hand and said, are we going to just talk about what we normally talk about, or are we going to admit that women are breastfeeding? And I'm like, no, my patients don't breastfeed. They're like, yes, Mona, they breastfeed. I'm like, no.
Yeah.
It took them 10 times to basically yell at me to realize, wow, I may have really missed the boat on this.
Yeah. Good for you for being open to that and creating a space where they would tell you.
Yeah, but it took a long time for me to realize it. I always thought, that I counsel my patients on that my HIV positive pregnant female patients that we have formula programs in Canada. It's recommended that women do not breastfeed with HIV and that they exclusively formula feed, so that's what you do. And so about 5 years ago, we started the dialogue. And I realized that, maybe I'm going to counsel my patients not to breastfeed, but to have the discussion was really important.
So maybe tell me, how did it shift? How did it start shifting? And maybe what are 1 or 2 takeaways you would have for somebody who wants to start making that shift in their practice?
I think just starting to talk to your women patients. So I've started to, rather than spend 10 seconds saying no breastfeeding, to really just say, what are your plans? How do you feel about not breastfeeding?
So you're inviting a conversation now instead of a directive.
Exactly.
And how is the response different from women?
They've appreciated it, and women are smart. That's really, and that they've actually really thought about it. Just because I haven't brought it up doesn't mean that they're not thinking about it.
Right.
So talking about what is their plan. Most patients indicate that their plan is to not breastfeed, and that at first they may have been sad, but then they realize that the best thing for their baby is to not breastfeed, and that they're going to get formula, and that there's other ways to bond with the baby. To talk about that, to talk about who they've disclosed their HIV status to.
So important.
And will not breastfeeding lead to any involuntary disclosure, and are they prepared for that? What are their plans for that? And to talk about if they haven't disclosed, that it's their right to keep their HIV status a secret, and that it's important to create a plan of how you're going to let people know that why you're not breastfeeding.
Right.
And as in the talk, one of the questions was about coming up with a lie. And actually, working with patients about coming up with a really good lie.
So a story for them.
A story for them, that fits with them, that they can tell people of why they're not breastfeeding.
And then you guys did an amazing thing with your community forum. Tell me about this.
Yeah, so after that conference 5 years ago, what we decided, whenever we have an issue, or usually when we have an issue in Toronto, we say, okay, well, if there's a really big issue, we have to ask the women themselves.
Yes.
So that's what we decided to do, and it took us a couple of years to get off the ground, but in 2013, we held a community forum where we invited probably about 40 women with HIV from across the province of Ontario that came, and we had a series of lectures on different topics, basic science, the clinical studies on HIV and breastfeeding, the guidelines that are available now, which are a bit contradictory and confusing. We had someone present, we had a lawyer present actually on the criminal issues related to HIV and breastfeeding, and it was really exciting to be all together in one room, and to really it's a start of a dialogue, and I think it's exciting.
What do you think are some of a challenge that you've had, a success you've had, and what's next?
Well, I think the successes and challenges are best probably described with cases. So. And the challenges, a lot of them, they have to do repeatedly with issues of disclosure. Probably one of the most challenging populations we have in Canada are immigrants from the Horn of Africa, which would be like Ethiopia, Eritrea, where there's huge issues related to fear of disclosure, a lot of stigma in that population. There's stigma and fear of disclosure everywhere, but in this part of the world it's particularly pronounced. And
particularly related to breastfeeding too.
Right. Yeah. So then what happens is they're HIV positive, they're pregnant. We in the hospital, we have the hospital that we work with that they put a label, a clear, like a white label over the IV-AZT. Oh, you guys don't use IV-AZT anymore.
Well, we do if people have
So that
in some cases,
people don't know what's being given. So that's kind of interesting. But then when they go home, their mother-in-laws are going to be there with them for 3 months, and is going to expect them to breastfeed. You know, what do we do? And I had one case like that where the pediatricians were arranging to have the woman move to a women's shelter while her in-laws were going to be there, so that she wouldn't have to deal with them. And I thought about the whole situation, and I said, I'm not sure that that's the best thing for the mother. You know, maybe we should support her to breastfeed. Or what does she want? Let's ask her what she wants. Does she want to breastfeed, or does she want to formula feed? And because maybe she does want to be in the house with the in-laws. That was a challenging situation to figure out what to do. Luckily, the in-laws didn't get visas to come, so they didn't.
You didn't have to deal.
So we didn't. Okay. Yeah, we didn't have to deal with it, and she was fine and could formula feed.
So, what do you think's next? I feel like you guys are on the cutting edge of this great conversation, and particularly with all this community dialogue. So, what do you think are the next steps for you?
I think so. We've started to make some counseling tools.
Oh, beautiful.
Yeah, so I know you have also, and so we've started to make some counseling tools on HIV and infant feeding. And we're doing a bunch of research. We're doing a systematic review on what is the risk of HIV transmission
and important.
through breastfeeding if the woman's on antiretroviral therapy with a fully suppressed viral load. We are doing some webinars. And I think, we're doing a bunch of commentaries because there's different perspectives, which is also really important to capture. So there's the perspective of the woman, there's the perspective of the adult doctor, there's the perspective of the pediatrician, there's the perspective of the midwife. So actually, hearing all those different perspectives are important. So we're doing that, and probably will culminate in hopefully we don't have specific HIV infant feeding guidelines in Canada. So we tend to use the American DHHS guidelines, and the UK has guidelines, but we don't have them in Canada. So we're hoping that eventually, after all of our the body of work is done, we can come together and create counseling guidelines on the topic.
Awesome. Thank you for all you do.
Okay.
This is so exciting.
Okay, thank you so much.
Detail about this important work.
Okay, thank you.
Thanks.